Hi, today I am so delighted to meet you in the program of JIP's Horse and Hot News. Yesterday we received a patient with 3 days of fever. Patient was subjected to complete blood examination which revealed leukopenia, WBC 3700. When somebody presents with leukopenia in the presence of fever, it conveys two important information. One, leukopenia signals that you are dealing a viral fever. Second one, broad spectrum antibiotic is not warranted. These two things you have to be reminded always. One, you are almost dealing with a viral fever. Second one, hastily you don't need to introduce any broad spectrum antibiotic. Hence, if leukopenia is found out around 3rd day or 4th day of fever, anything less than 4000, then probably you have many causes of viral fever. So, clinically significant viruses are, one is dengue and chikungunya and COVID and flu. These are the 4 important clinically significant viruses. How you can differentiate each one of them? By means of clinical examination and investigation. 1. Dengue and chikungunya both can produce severe joint pain, but the delicate differentiating point would be chikungunya involves joints. They will have arthralgia, to some extent they will have arthritis, inflammation of joint, especially even the small joint and ankle joint, major joint, everything. So arthritis would be a very favorable future of chikungunya, even though they may complain diffuse myalgia. But this arthralgia or arthritis, specifically arthritis, is not seen in dengue fever. So, if somebody presents with leukopenia and a classical arthritis, you can think of chikungunya. But first initial 5 days of fever, chikungunya fever doesn't elicit IgM antibody. What I am trying to say is that IgM antibodies will take at least 5 days to get developed in our blood. So before 5 days of fever, if you suspect chikungunya, you have to do PCR test through blood specimen. If the duration of fever that exceeds 5 days, then you can order chikungunya IgM antibodies. Otherwise, even if patient harbors chikungunya virus, if you order chikungunya IgM antibodies before 5th day, it may turn out to be negative one. And for dengue, most of the time they will present with severe body pain, especially with back pain. Arthritis, we are not witnessing much, to be honest. So for dengue fever, again like chikungunya, after the 5 days of fever only, IgM antibodies will be produced. But before 5 days, you can order dengue NS1 antigen. NS1 antigen can be formed as early as 2nd day of fever. Then, what about flu and COVID? Both these viruses produce respiratory symptoms. If they present with sore throat, sneezing and cough, then definitely you can think of both these viruses. These upper respiratory symptoms are really lacking in both dengue and chikungunya. If respiratory symptoms are present with leukopenia, then definitely you can think of chikungunya and flu and COVID. Since COVID viruses are not prevalent, we are able to see lot of flu cases, for which you have to do throat swab for H1N1. So there will be some confusion about H1N1. and influenza. So influenza virus you will have type A and type B. There are so many subtypes are there, H1N1, H1N2, H1N3 and so on. But why sometimes H1N1 and influenza type A and type B are synonymous are, this H1N1 is the most abundant type that is isolated among these subtypes. That's why we always specifically refer H1N1. But ideally we have to order influenza type A and type B, then they will isolate the organisms. Isolate the subtypes. So these are the viruses commonly produce leukopenia. And when somebody has leukopenia and when you are certain that you are dealing with viral fever, one more important investigation that is often ignored or neglected in our clinical practice is estimation of liver enzymes. Yes. Instead of doing liver function test as a whole, at least you can do SDOT and SDPT in view of financial restraint of few patients. If SDOT, SDPT are elevated, it gives much or it strengthens our findings of viral fever. Generally these viruses, whatever I have mentioned, these 4 viruses, then even some of the viruses, respiratory syncytial virus, adenovirus, whatever it is, they can produce elevation of liver enzyme to the extent of 100 to 150 international units. So SDOT, SDPT elevation, marginal elevation would be a part of any viral fever up to 100 to 150. If somebody presents with leukopenia and SDOT, SDPT around 500, 600, then you have to switch over your loyalty to hepatotropic virus like virus hepatitis A and B and C and E and so on. So these hepatotropic virus can produce moderate to severe elevation of liver enzymes. So don't forget to do SDOT, SDPT in the presence of leukopenia. Even when you have leukocytosis, when you suspect bacterial fever, at that time SDOT, SDPT elevation also may signal that you are dealing with sepsis. So for all practical purposes, better to do SDOT, SDPT as a part of fever profile other than complete blood examination. Then somebody presents with leukopenia around 5th or 6th day, then if you look at platelet, then there is an evidence of thrombocytopenia, then probably you can think of viral fever. So most of the viral fever, it will produce leukopenia as the earliest blood cell abnormality. Then after 4th and 5th day, the thrombocytopenia gradually emerges along with severe leukopenia. At some point of time, thrombocytopenia would be severe at the end of 7th day, especially dengue fever, where the thrombocytopenia can be evident to an extent of as low as 10,000, 20,000 and so on. So leukopenia and thrombocytopenia are part of viral fever, but leukopenia would be seen in early stages, but there would be normal platelet count. But after 3rd and 4th day, leukopenia would be severe and thrombocytopenia will emerge gradually. At the end of 7th day, you will have severe thrombocytopenia and severe leukopenia, especially dengue fever. So dengue fever is notorious in producing thrombocytes as low as 10 to 20,000, unlike other viral fever. But around 5th or 6th day, if somebody has only leukopenia, 3,500, 3,700, but platelet count is retained, if there is chills and rigor, then think of enteric fever. Yes. So most of us are aware that enteric fever can produce leukopenia. So enteric fever commonly produces leukopenia after 5 days, and most of the time leukopenia would be alone present. Thrombocytopenia won't be present. If at all thrombocytopenia is present, probably it may be a mild thrombocytopenia around 1,30,000 or 40,000. There may be mild elevation of SGOT, SGPT, we used to call it as enteric hepatitis. So how will you differentiate between the leukopenia of enteric fever and leukopenia of dengue and other viral fever? In leukopenia in viral fever will appear on as early as second or third day of fever. On the other hand, enteric fever only after 5th or 6th day. In viral fever, after 5th day, you will have both leukopenia and thrombocytopenia, and enteric fever, you will have only leukopenia. Platelet may be preserved. And another important clinically, most of the time viral fever, they will have fever and body pain, but in enteric fever, they will have fever and severe chills and rigor. Even you can imagine to the extent of you are dealing with malarial fever. So chills and rigor around 5th or 6th day with mild leukopenia in the presence of normal platelet count, think of enteric fever, draw the blood for blood culture rather than going for Vidal, because Vidal to be done at the end of first week, and serial elevation of agglutinins in Vidal test would be paramount rather than the isolated elevation of single Vidal test. The blood culture may throw good light on harboring enteric organisms in the patient's blood. And one more cell abnormality I want to explore. When you have isolated thrombocytopenia like 1.2 lakhs or 1.1 lakh, even 80 lakhs, in the presence of normal WBC, then you can think of a couple of differential diagnoses. One, malaria and leptospirosis and scrub typhus. But malarial fever, you may have periodical shivering, and lepto and scrub typhus, they can have fever and chills and rigor. And lepto and scrub typhus can involve liver to a great extent. SGOT, SGPT around 200, 300 can be elevated. Even malaria also can produce malarial hepatitis. So I think that all these organisms can be separated by lab investigation or distinguished by lab investigation by malaria QBC and lepto IgM and scrub typhus IgM and so on. So with this, I would like to end the how to evaluate fever with leukopenia. And one more case we received 2 days before. Patient presented with hemoglobin around 7 gram, 51 years male. I used to insist always that when you find anemia, always look at mean corpuscular volume. If mean corpuscular volume is less than 80 femtoliter, 4 differential diagnoses. The code word would be ILTS, I, iron deficiency anemia, L for lead poisoning, T for thalassemia, S for sideroblastic anemia. Out of 4 causes, iron deficiency anemia would be the leading cause, 90 to 95% cases in the adult. So this patient we strongly suspected iron deficiency anemia. But the important caveat in evaluation of iron deficiency anemia in adult is, don't take it as iron deficiency anemia as a simple one. It is nutritional deficiency mediated. Any adult male who presents with iron deficiency anemia, I mean hemoglobin less than 12 gram with decreased MCV, think of blood loss from the GI tract. Very, very important. Iron deficiency anemia in adult always draws attention towards evaluation of bowel malignancy or upper GI bleed, secondary to peptic ulcer. You have to explore. Then one more patient admitted with acute pulmonary edema. Yesterday, patient was on BiPAP ventilation. Patient has been started on Lasix infusion and dobutamine, considering the low EF, only 18%. So with this, I would like to end this session. Thank you.